vibe, we shine on the light. We all over the world, chat night Africa. We all over the world, chat night Africa. Welcome to chat night, we bring you good vibe, we shine on the light. Welcome to chat night, we bring you good vibe, we shine on the light. We all over the world, chat night Africa. We all over the world, chat night Africa. Welcome to chat night, the only place that we give you good vibe. Chat night Africa. Welcome to chat night, all over the world we are shining the light. Chat night Africa. Welcome to chat night.
Hello, my friend. Thank you for deciding to watch this ebullient broadcast. Today, we confront the reality of prostate cancer. We will break the silence, dispel the myths, and empower you with information that can save lives. Stay tuned as we drill down into the facts, the risk, the latest advancements, and most importantly, the hope that exists. This is your health. This is your life. This is about understanding prostate cancer. My name is Divine Chamakong, and I'm anchoring this broadcast from Washington, D.C. metropolitan area. Assuming at this point that you are well ready for this jaunty broadcast, let's now welcome the erudite professor of oncology, Dr. Edmund Folefac, on the platform. Doctor, thank you for accepting once again graciously to come and take some questions, this time on prostate cancer on Chat Night Africa's Healthline.
Thank you, Divine, and thanks to our viewers. Hopefully, I think we would be able to educate our people about this very common, albeit quite misunderstood disease called prostate cancer.
Before we jump in, this important announcement. Ladies and gentlemen, going forward, Facebook no longer keeps live videos beyond 30 days. So, what do? Go to YouTube and search Chat Night Africa, or to www.chatnightafrica.net to watch our shows in high definition. As already said, the guests, our distinguished speaker on the platform is Professor Edmund Folefac. He is about to get into a very, very instructive, insightful discussions with me on prostate cancer. Thank you for joining us. Doctor, is it fact or fiction that frequent sex reduces chances of prostate cancer?
So it's both fiction, but I can see where that fiction comes from. And possibly maybe said there's a little veneer of possible fact. And the veneer of fact, probably one of the most cited study on this issue goes back to the Harvard Men's Health cohort. And that was a study that actually looked at over 30,000 men and who were followed up, for prostate cancer. And then they started being interviewed probably at the age of, I believe in their later years. And they tried to figure, and then they asked them, sent out a survey questionnaire to find out from them the number of, ejaculations that they had in their 20s, and then between their 20s and their 40s, and then their 40s upward, up to their 50s, I believe. And what they concluded in that study was that there was some evidence that people who had more frequent ejaculations in their 20s actually had less, risk of developing prostate cancer. And then there were some other studies that were done, quite didn't replicate as much the same result, but maybe pointing to the fact that maybe frequent is actually ejaculations may actually reduce the risk of prostate cancer. It's really not sex per se, but just the number of ejaculations. And I think one of the things that they kind of like started thinking was hypothesizing, as you know, in science, when we find a result like that, the question to us is always why. And some of the hypothetical, thoughts there were that maybe as the people, as men ejaculate, they kind of rid themselves of potential cancer causing chemicals that would be in the prostate. So again, that's not something that I'm going to advise people to do just, to avoid, to reduce the risk of having prostate cancer. There are better things to do to reduce your risk of prostate cancer.
Some men are said to have reduced or refused treatment for fear of losing their sexual potency. What's your response to that, sir?
First, it's one sympathizes with the men who develop prostate cancer and yet, get very concerned about sexual health, either post-treatment of prostate cancer. But one has got to admit that it's only living men have sex. Dead men don't have sex. So you got to think about it when you have a disease like that, and the treatment is one that may ultimately, in some cases, decrease your one's erectile function or one's ability to be able to have sex. You got to think about what is more important. Is it life, or is it having sex? Now, and also the level of the level at which the cancer is diagnosed and the treatment that one gets actually and determine how much of that sexual function one is going to lose. Now, for people who develop prostate cancer that is still localized to the prostate and they have surgery, if you have surgery in the hands of an expert, such that in taking out this prostate, they could leave out the nerves that control erection, then that and then post surgery, you have somebody who also is an expert, and then they start what we'll call rehabilitation, i.e. things like pelvic floor exercises, giving people medication like Viagra, to start to rehabilitate the penis, and then using sometimes the pumps and all of that stuff. That really can, to a large extent, mitigate, the loss of erectile function that would have otherwise occurred. And of course, for people who get radiation and hormone therapy, the hormone therapy usually is the thing that reduces your testosterone, and testosterone is what actually drives erection. And if those people that tend to have their own issues with erection a little bit later compared to the people who have surgery, those people tend to have their own erection issues early on, and then with time they may regain some of the sexual function back. On the contrary, some of the people who get radiation and hormone therapy, during the time of radiation and hormone therapy, yes, the sexual function is going to really be almost not there. But then there are other things that we can do to actually help people regain or maybe also still have sex during the period of treatment and post-treatment. Once we take away the hormone therapy, your men's testosterone tend to come back. And then we did also regain some sexual function. The last thing I have to actually mention about this is also the fact that, one has to remember that, by age 50, already about 40% of men would have started having issues with erection, and sometimes some of them would have actually lost it altogether. And then by the time you get to 65, 70, that percentage can go up to about 60. And sometimes when you are actually in this kind of situation, the people don't always know that they would be able to adapt. But then once they get treated, then you find new meaning in life. You find new things, especially if they talk to their partners. And so just because you don't have sex doesn't mean that you can't have intimacy. Doesn't mean that you people cannot have that it doesn't make you any less a man. I think there is too much about being a man than having sex. And I'm really stressing on this point because, as probably we'll get into this, that prostate cancer is a disease that affects us black men more than any other race but sometimes because of years, fortunately seen uh, men who, because of this fear, they fail to treat the cancer even when it was still very early, and then by the time they come they come to the attention of the doctors, the cancer has advanced to the point where they're now dealing with an incurable disease and ultimately, suffer and die. That's really why some of these issues are very important. So to address upfront.
We'll come to that, sir. Should all men be screened for prostate cancer?
I would say not all men should be screened for prostate cancer, but men up at a certain age, right? I mean, so start for black men, I would say at the age of 45. Ideally, everybody should be screened for prostate cancer. Now, if your family has had prostate cancer, like if you have a father who had prostate cancer, if you had a sibling who has prostate cancer, this doubles or sometimes triple your risk. And therefore, your age of actually starting screening for prostate cancer should be a little lower. And I would say even about 40. Now, if you have one of those genes that actually confers a much higher risk of developing prostate cancer, these people should really all be screened for prostate cancer. Now, when we talk about screening, also remember one of the real reasons why, I mean, the main reason why we screen is to diagnose disease at an early stage. Now, if you are diagnosing disease at an early stage for somebody who has a lot of comorbid conditions, and therefore, even if you found it, you will not be able to treat it. So why screen? And that is the
So,
only
but
reason.
what kind of screening are we talking about here?
Now, the PSA, which is a kind of protein that is produced by the prostate, called prostate specific antigen. And the reason why that's specific there is because it is mostly produced by the prostate. Now, that is the thing, it's a blood test that we use currently. And I say currently because there's a lot of research to be able to see whether we could use other things, that in the urine. And the PSA is such an abused and such a misunderstood test, and which it's not really just the general public, but unfortunately, even the task force, the U.S. Preventative Services Task Force, which is kind of like the gold standard task force in the world, actually for over the years has actually misunderstood and unfortunately sometimes given guidance that didn't really always pan out to be really good for people. Now,
But the
mhm,
PSA is supposed to diagnose or catch cancer, prostate
right.
cancer at an early age, therefore reducing mortality rate.
Mhm.
Why is there such argument? Why do you have arguments among you professionals for and against something that's supposed to be a good thing? The PSA.
So it is always good to talk about, when we talk about professionals, let us understand what we're talking about. I'm a doctor, I'm an oncologist. If it comes to, if we're talking about heart issues, I would defer, even though as a doctor I know quite a lot about the heart, but I would defer to my colleagues who are cardiologists. If we were to talk about lung issues, I would defer to my colleagues who are pulmonologists, even though I know I have some a real quite understanding of what issues of the lung. And so when it comes to cancer screening, we should not only defer, we cannot just say colleagues, but who are these colleagues? I can tell you that amongst the people who are oncologists, especially those of us that are specialized in this particular cancer, prostate cancer, there is close to unanimity in terms of what to do with the PSA. And the reason I kind of said that was also the PSA, it's a protein that is produced by the prostate. So normally everybody should produce some PSA. And there is just no standardized level of PSA below which people don't have cancer and above which people have cancer. But we have a PSA level above which it starts giving us an idea that the probability that you have prostate cancer is high. And that PSA is supposed to be just get you into the door to then use it as a screening tool, then decide which way to go. Now, some people would get PSA and then will say, okay, you have to have a PSA every 2 years. And some people will get a PSA and will say, hey, we need to repeat this PSA in 6 months to determine what we are dealing with. Some will need to have it every year. Now, whatever the case, when you have a PSA that we consider, the lay public there actually, or maybe even other doctors who are not oncologists, they know this PSA and take about the PSA as and have this kind of dichotomized value of 5, where, or some people take it as 4. So as a PSA below 4 means you don't have cancer, and a PSA above 5 or 4 means you have prostate cancer. That's not also true. Now, if you have your PSA, the older thing about the PSA is that the PSA also changes. It varies with age, and it varies with somebody's size, the size of somebody's prostate cancer. But more importantly, it is the change in PSA. So in other words, and then if for men at 40 already, every man would notice that, you start after 40 into your 50s. One of the things that is that you start not being able to hold your urine as much as you used to. You get to the bathroom, you tend to know places where the bathrooms are a lot more than you used to. And the reason is because your prostate is getting bigger. And as your prostate gets bigger, it means it also can produce a lot more of the PSA. And therefore, an enlarged prostate that is not cancer also has the ability to produce PSA even higher than 5 up to a certain level, in some cases even up to 10 or a little more. But if I check your PSA now, and then I checked it next year, and you go to your doctor checks your PSA, get that number. Whatever that number is, that is the most important thing, get that number. The following year, especially as a black man, check that PSA, let them check that PSA again. If your PSA has gone up from what it was the previous year, then somebody needs to think about getting to the next step. And that next step should be the doctor needs to do a rectal exam, feel your prostate, see what your prostate, a normal prostate should be smooth. But if your prostate is not smooth, there may be a knot. If there is not a knot, that can actually tell us, hey, this is the person that needs to go be referred to biopsy. Then they check it again. If it continues to go up, they need to send you to a urologist. The urologists are our colleagues who would help you, do a biopsy. It is that biopsy that ultimately would tell us whether you have prostate cancer or not.
But when you talk about cancer, time here is of the essence.
Yeah.
I go and check my PSA. I'll be doing annual fiscals end of this month. I go and check my PSA is at a certain level. Am I going to wait for another year, which could prove very valuable if I had started treatment before doing the second PSA for all these confirmations to be done?
Yes, that absolutely. The prostate cancer, it's not it's not like some other cancers, right? Like in America, for instance, and I'm quoting America just because we have a lot of the data,
Correct.
one in every, like 12% of men, that means one in every, probably roughly 8, or let's say one in every, would have prostate cancer over their lifetime. Now, but the percentage of people who actually die of their prostate cancer is only going to be about 2.5%. So an overwhelming
Oh,
majority of the people with prostate cancer, that cancer is never really going to affect them. We know this because it's actually when you do some of these people who have the low level prostate cancer, Gleason 6, PSA less than 10 generally, as I said, these people, these cancers, they may harbor these cancers for decades upon decades upon decades, and it will never cause them any problem. So the key when we screen is to find out who is that person whose prostate cancer over their lifetime would cause them problems and or progress and kill them, and who is that person whose prostate cancer is never really going to hurt them in their life, or and you leave them alone.
and at this point, would you tell you as an oncologist, would you tell somebody whose prostate cancer, I would say, let me use the word benign, if
Right?
that's appropriate, are you going to tell the person he
Slow. I
has prostate
prefer the
cancer?
word slow growing, right, rather than benign, because when you say benign,
Okay,
by its definition, it means that it is not cancerous,
okay.
right? So slow growing probably would be much more appropriate for our audience.
So would you tell the person that he has slow growth cancer?
Yes. So that is the whole goal of screening, right? So the whole goal of screening is to determine, number one, do you have prostate cancer or not? And then if you do have prostate cancer, then what kind of prostate cancer do you have? Is it a cancer that already at the state at which we should treat? Or is this a cancer that we should monitor you? Currently, we do something that we would call, for those people who have very low risk prostate cancer, and we'll get there, a slow growing prostate cancer, because we think about them in our own language as risk, low risk, high risk, medium. I mean, low risk, medium risk, high risk. Things like that. So for people who have very low risk, or low risk prostate cancer, i.e., a Gleason of 6, as I talked about, and a PSA of less than 10, generally, we are going to say that we could put you on the protocol that we call active surveillance. Now, by the word active there is very important. Surveillance means, and active there means, what it entails is every 6 months we may check your PSA again, and then every year we may do a biopsy. Now, knowing that some of those cancers, a few among those cancers would eventually progress, to a level that we need to treat you, we are trying to make sure that we don't treat people who don't need treatment. Now, currently in
Okay.
America, about 60% of men on that group, that's Gleason 6, PSA less than 10, they are actually are now enrolled in a lot of active surveillance protocol, and which is really nice in the sense that we're not treating people, treating people who don't need treatment. The problem sometimes arises when some of the men get so anxious, or to even do also, like, it's almost like I'm telling you, oh, maybe that if somebody tells you that you have cancer, it's like, oh, they like caricatures of monster under your bed. But do you know what? One of those can actually be a monster. But maybe we should just wait, because even if it was a monster, there is a certain sound, there is something that it would do for us to be able to know, to determine whether it's a monster or not. I'm sure some people just come and say, no, 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 I don't even want to think about it. Just get the prostate, get it out or treat it. And that's what really it is that overtly aggressive, and really also not only the patients but also some of the physicians, when we're still in a place where we didn't really understand this much better. And frankly, there were also some physicians, I should say, who really for reasons other than just taking care of the patients, just did get involved, either took out people's prostate or sent them for radiation and hormone therapy, which are the two treatments that you use for localized prostate cancer. And that really got so many people then have complications from cancers that from the cancers that should never have been treated because it would never have caused them any problem during their lifetime. I should mention that by the age of 70, almost about 6 or 10 about 6 or even 7 out of every 10 men may have, if you took down their prostate for any reason other than treating them for prostate cancer and sequence it, send it to the lab, you're going to see cancer cells in there. But again, it is a very small number that ends up dying from this prostate cancer. And that is why it is very, very important to understand, number one, what should you do? But then number two, if they tell you that your PSA is high, don't panic. Get somebody who understands the PSA story to tell you what next to do, which is definitely going to be a biopsy. And if they do a biopsy and they tell you have prostate cancer, again, don't panic. What is the value? Now, if it is a Gleason 6, it's a PSA with a PSA of less than 10, ask your doctor whether they have active surveillance protocol within your area, or they are, if not, find out places where they can do this so that they can actually you can actually get enrolled in that active surveillance protocol. Now, few caveats. Your prostate is like an apple. When you go to get a biopsy and somebody, imagine they split the prostate into 2 parts and then split it again into 3 each side, so that on each side you have 3 parts. On the right you have 3, on the left you have 3. Then they will go in each one of those and take a needle, put in a needle and take 2 pieces. We call them cores. So they take 12 samples, overall. What we're actually looking for is the area of the most aggressive cancer. And in some of these cases, we do miss because you're doing it, you may miss the area of more aggressive cancer and give somebody the false impression that they don't really have an active an aggressive prostate cancer. Meanwhile, they really actually do. And so these are the things that the doctors must really take care of, be aware of, and make sure that they actually do testing such as an MRI or currently, or some types of genomic testing, to make sure that when they tell you that the cancer is slow growing, it is really that it is slow growing, just so that we don't give you false information and then you go and eventually the cancer grows and causes you problems.
I can tell you that if you tell somebody that he has cancer, they are not listening to what all those numbers are. All they have in their mind is they have cancer. They have this monster under their beds, and it can be very scary. I'll come back and just for us a moment to have a musical interlude for about a minute or so, and we will be right back. You are watching a show on prostate cancer. Men, take note and talk to other people about this show. My name is Divine Chamakong. I will be right back. Watch this.
Hold my hand, never let me down. Hold my hand, you gotta hold my hand, yeah. Take my hand, let me see your face. Give me strength to push on through. Let me live.
And this show is broadcast on www.chatnightafrica.net on the internet. And through that platform we are hitting the four corners of the planet. Ladies and gentlemen, once more, join me in welcoming this powerful oncologist, Professor Edmund Folefac, once more on the platform. Doug, at this point, I'm going to ask you the question, what are the symptoms of prostate cancer?
So, for prostate cancer that is a little more advanced, people begin to notice things like difficulty urinating. You may they may notice that they have to get up at night more frequently than usual, and then they may notice sometimes blood in the urine. And they notice that they don't empty their bladder as much. But if it's more advanced, that in cases where it's already caused more, does what we call metastasize, which has traveled and gone to places like the bones or stuff, then pain may become an issue. Now, but that said, some of those symptoms that we just mentioned, problem peeing more often, feeling like you don't empty the bladder, and even some blood in the urine. Those are not only most men who even notice the symptoms are likely going to be caused by, more caused by the BPH, or benign prostate hypertrophy, which means an enlarged prostate, because there are more cases of enlarged prostate than there are actually than there are cancers, prostate cancer. So that's really some of the things that we think when we think about the symptoms. But by and large, most men who actually, and that is the beauty of screening, sometimes don't even have symptoms. If you are screened, you're just screened for, again, getting your PSA check, and we hope that we get men with the prostate cancer through screening, because then we can cure, then we can actually, have a very good conversation, and then decide to on how to manage the cancer and provide them, a cure, as opposed to much later where it becomes much more of trying to prolong life. And
Usually people don't act until they perceive a threat.
yeah.
You talk about frequent urination. Sometimes I get up from bed in the night and go to the bathroom twice.
Yeah.
Is that frequent? Should I be worried? What is frequent urination?
And so it depends on the individual, right? I always say, know yourself, know your regular normal body pattern. Now, if you've been one of those people who, for over the years, you get up at night, once a night, and then over time you start getting up multiple times. But if you're getting up multiple times, there could be so many other reasons that might cause that. So don't just panic. Don't get, there's something that we used to call the medical school syndrome, medical student syndrome. You get to class and then they teach you one thing, and then your mind, any little symptom that you have very remotely similar to that, you think that is the problem that you have, right? So every medical student knows this. But I want to say, for instance, there are so many other reasons why you may get up at late at night. People who drink beer, right? If you drink beer, beer is a diuretic, so it causes you to pee more. So people are gonna get up more frequently and pee. So it's not prostate cancer. If you have, even some people may have we just talked about BPH, where we should talk about things like diabetes, where you're getting up at night more frequently just because there is too much sugar in your system that is causing you to pee. Or maybe sometimes people have prostatitis, an inflammation of the prostate. That's not also prostate cancer, or things like that.
Granted, I get it. But
Yeah,
if you begin to urinate frequently, more frequent than normal, normally go see the doctor, or you're having blood in the urine. Say you have prostate cancer, what stage would that be? At what stage would that be? One or two?
So we at that time you cannot tell, right? When you see the doctor is going to say, first they're going to measure your PSA, assuming that you do not already previously have PSA checked. And of course, a good doctor would take a history and determine, is it an infection? If you have an infection, then the infection itself may actually even cause your your PSA to be a little bit unusually high. So if your PSA is high but it's not too high, the doctor may say they may treat you for infection, they may treat you for anything, and then have you come back. But eventually, let's say you eventually get diagnosed with prostate cancer. Now, with the PSA that is high, it's not going back. It's not going down. And then they send you to a urologist. The urologist then do a biopsy. And as I was describing, they take samples. In that apple that I just mentioned, imaginary apple, they take 12, pieces of those of the prostate. We call them cores. They send them to the lab. The pathologist actually looks at this under the microscope and compare the cells in that prostate on that specimen to what is a normal cell. Now, the more the further out, the more different those cells are, the more likely that it's a cancer. So we do something that we call a Gleason score, and that Gleason score, it's actually named after the person who actually looked at this to be able to remember, as I told you already, that some of these cancers, most men who have prostate cancer may never die from the prostate cancer may never cause them any problem in their lifetime. That's how we try to figure out. So you imagine that on this side, there is a normal cell, and normal cells, if you look at them under the microscope, they will be very, very uniform. If they are 1,000, they look very uniform. Cancer cells, they will be very disorganized, very chaotic looking. Now, if you put this very chaotic looking here at 5, then the normal cells here at 1, 2, we just consider it as a variation of number. 3, we say, okay, you're having cancer that is somewhat not that advanced, but 4, we begin to think, yeah, this is a cancer that may be aggressive. 5, it is very aggressive. So we kind of like we do something that we call the primary pattern. It's the most number of cells looking like, and then the next most number of cells, how do they look like? So we put these two together and then give you a score that ranges from 6 to 10. Now, that score that ranges from 6 to 10 allow us, along with your PSA, along with the extent to which the cancer has invaded the prostate, we get these numbers and we can call it low risk, intermediate risk, high risk, very high risk, or if it's a cancer that has actually then traveled out of the prostate, we call it metastasized. So we don't stage prostate cancer. Usually if you go and talk to your doctor, they're not going to stage prostate cancer like you hear stage 1, stage 2, stage 3, stage 4.
Okay.
We have our own, but you're going to hear that you have low risk, intermediate risk, high risk, and that for us actually gives us an idea of what we're dealing with for people who have localized prostate cancer.
Now, given the controversy surrounding PSA, are there other screening tools as alternative to PSA?
So,
because PSA, when I listen to you, PSA seems to be the gold standard.
Again, the PSA is something that gets you a step to the door of prostate cancer screening, right? So it's a simple test. It's a blood test. So anybody can have it done at essentially very low risk to you. When you have it, then again, just because the PSA is high, it doesn't necessarily higher than what the lab, when you go and get your lab test, I think the first thing that comes back to you is, as always, if it's actually outside of the range, in this case, higher than what the range is, what is considered conventional upper limit of what is normal, then they will mark it as red. And then they say, oh, your PSA is high. But the point I'm trying to make here is that just because your PSA is high does not really necessarily mean that you have prostate cancer. But it's a good tool to be able to get you to who should we screen. if you do a PSA, for instance, so somebody, and the PSA is 2, and that person is in their 40, 50, I mean, in their 60s, I'm not really going to worry about that. I'll just say, let's just check it again in another year, especially if you're a black man. And we're doing that because we know those numbers could change. Now, once you get that PSA, and we then know that, we then see that, yes, it may indicate cancer. Again, the things that we can then use, things like MRI, right? To be able to say, how does your prostate look? And then we can say, okay, we have to biopsy, because biopsying is the gold standard. There are now tests for genomics where some people, even though we may do a Gleason and the Gleason may be may not be that high, it may be we're trying to figure out and make sure that we are not giving you some false hope. Especially if I see a man who has a family history of prostate cancer, they have a Gleason 6, and they are still young in their 40s, 50s. That is somebody that I would want to do a little bit more. What are your genomics? Is it a 6 that is likely to go to a 7 and then to an 8 and blah, and so on? Or is a 6 that is going to stay at a 6? So I would get that. But if it were a 60-year-old person with a Gleason 6, I have less propensity to do more testing. That way we can say, okay, let's just do that active surveillance. So PSA, again, is an entry to the door, but you need to know that there are all these other additional things that would allow us to determine whose PSA of 6, whose PSA of 7, whose PSA of 10, whose PSA of 11 really needs much more additional, work. And when we do a biopsy, who is that person? If you have a prostate cancer, whose prostate cancer do we need to treat right then and then? Or whose prostate cancer do we need to be able to not treat, and then you put them on that protocol that we call active surveillance? Again, genomics would help us. Then the nature of your PSA, the trend, would help us. And then sometimes these MRI things that I mentioned would help us as well.
You have gone and met your primary healthcare doctor. You run the test for your normal annual physicals, and then you get that unpleasant call. Come to my office. When it isn't a nurse telling you what, maybe go get your prescriptions. They're asking you to come see the doctor. That's a red flag right there. Anyway, so you go and meet your primary healthcare doctor. He says, well, looks like your PSA is high.
Right.
Who in line are you going to see next? Is it an oncologist or a pathologist? I mean, I've never been to a medical school. So who are you seeing next after your primary healthcare doctor?
Most primary care doctors, the next thing that they're going to tell you to do, they will do, may be to do a rectal exam. They will feel your prostate through your rectum.
Okay.
And like I said, the normal prostate should be very smooth. A cancer would be like a tiny little knot, so you may feel something a little hard on that prostate but then even if they don't feel it, they're going to send you, the next person is going to be to a urologist. The urologist is the person who is specialized in doing surgeries of the cancers of the urinary tract, that is the bladder, the kidney, the prostate. Now, it is the urologist who would take you, and do a biopsy. That biopsy is taking samples of that prostate as I've just described, and then they send it to the pathologist. The pathologist is that person who stays in the lab, reads and interprets those samples that were sent to them. It is when they do this, then they send back the information. Most primary cares will know. If they see that you have a Gleason, or the urologist whom you get to, if they see that you have a Gleason 6, then they will say to you, this is something, and if they have that, if they're a urologist that is specialized in cancer, they would say to you, they will offer you these two options: active surveillance versus definitive, what we'll call definitive treatment. If you chose definitive treatment, then we can talk about that. But if you chose active surveillance, it would entail you getting a PSA every 6 months and then doing a biopsy every year to keep determining whether that your Gleason score stays at that level and your PSA is not rising, to a level that would need us to do something different to switch you to definitive treatment. So yeah.
You are scheduled for a regular medical checkup,
Hmm.
what you could call annual physicals, say
Yeah.
tomorrow. Should you avoid sexual intercourse the night before? That is, if you're going to do a PSA, or briefly, are there certain things you should not do before you go and do that test?
Yes. People, if you have sex the night before, or people who ride even bicycle, sometimes we tell the doctors, if you want to do a PSA, get the PSA done before you do a rectal exam. Anything that is going to stimulate the prostate is likely to make the may make the TSA go artificially high.
Wow. You are watching Healthline on Chat Night Africa. My name is Divine Chamakong, and my guest on the platform is Professor Edmund Folefac. What's the best treatment for localized cancer, and what treatment provides the best long-term outcomes?
If you are determined to have localized prostate cancer, you have two, and you need treatment. And I say you need treatment because remember that I told you that some localized prostate cancers never cause you a problem, and you're one of those whom we determine you need treatment. Then you have two choices. Choice number one is to take out your prostate, what we describe as radical prostatectomy. They take out the prostate, and if they take out the prostate, then for the most part, probably I would say more than 2/3 of the people with localized prostate cancer are likely to be cured with that, especially the people, but if you're one of those who don't want surgery, the other option is to do radiation plus hormone therapy. Now, for radiation, they get the same standard radiation. Now, with different radiation techniques, the radiation oncologist would tell you different kinds of, radiation modalities that they can do. Then the hormone therapy, it would depend how the duration of how long you get the hormone therapy would depend on your risk. If you are a low risk, then we could do, if you're like the people on the intermediate risk, the Gleason 7, we can do 6 months of hormone therapy. If you do have, high risk disease, then we can do at least 18 months, sometimes a little bit longer. It could go up to 2 or 3 years, just depends.
I didn't hear you talk about chemo. Or did you
No,
say
because
chemo in
chemo
other
is not.
words?
No, we don't really do chemo for prostate cancer until later
Okay.
later on. It's only chemo in the prostate cancer is actually reserved for the advanced stages. That is, people whose cancer has metastasized. There have been some research looking at whether or not you can use for people who still have very high risk prostate cancer, the Gleason 10s, that you could do chemo to reduce the risk, to increase the chances of cure. But I don't think most of us do that. Chemo is really reserved for people whose cancer has metastasized. And even then, even at that, sometimes they would have gotten through other treatment before they get to actual chemo, what people know out there as chemotherapy.
Are there times some people are reluctant to have surgery?
Yes, there are.
Why?
Not everybody is a good surgical candidate, right? Some people may be reluctant because they just really just don't like the idea of having surgery. But the surgeon would also have to screen you whether you are actually a candidate for surgery. Are you able to withstand anesthesia? If you have a bad heart, if you have like people who are very obese, for instance, if you have bad diabetes, if you have things that would put you at an increased risk of surgery, then the surgeon is going to say, hey, you're not really a great candidate for surgery, so we should do hormone and radiation. I will have to say, that, let me just add that whether you do surgery or you do radiation plus hormone therapy, for the most part, if you take all comers in the in the in the localized prostate cancer space who require treatment, the outcome is about equal, right? So
Okay.
meaning that if you take 100 people and treat them surgically and take 100 people and treat them with radiation and hormone, you'll get the same amount of cure. So if that number is going to be 70 on this arm, is going to be about 70 again also on this arm. So it ultimately boils down to few things. What is the patient comfortable with, right? Then number two, what are some of the comorbidities? Sometimes some people don't are not good candidate for radiation either, just like some are not good candidate for surgery. But we give the patients all the information and then let them make their decisions.
Point taken. This guy with a very beautiful wife at home would be worried probably about taking out the prostate. If you when you take out the prostate, does it prevent the man from doing certain things like sexual intimacy?
No, I mean, like we said at the beginning, that the answer is yes, it's going to affect. Now, the prostate itself, there are some nerves that control erection. They run very close to the where the prostate is. A good surgeon will look at sparing those nerves, like taking out the prostate without interfering with those nerves. Even if they do, you're still gonna have ultimately in the long run sometimes a reduction in your sexual function. But most surgeons would not only not spare that nerve if the cancer has not already involved those nerves, um, but they would also post surgery help you do what we call rehabilitation by using drugs like medicines like Viagra to increase potency, doing pelvic floor exercises, which actually, and then doing things like sometimes they may do use some devices that keep the length of the penis in at the same. So
How do you know a good surgeon? Is there somewhere, a dictionary, maybe a reference book that I can go
so
research Professor Folefac, for example? What's your record in doing this thing?
yeah,
Is it
so
possible?
the good thing is that being in America, I mean, because we're in America, you can always research every doctor, right? You can check what patients say about them. You can ask the patient. You should be every doctor should be willing and then ready to discuss with you on what they do, what are their complications rate, right? Now, for the specifics of prostate cancer, and I want to say this specifically because of our population, because one of the reasons our people, black people, are more than they are diagnosed with prostate cancer twice as much as the white let's say about one and a half time more than the as much as the white folks, but then they die twice as more from their disease than the white folks.
Why is that?
And that's yes. So that's where we're going to get to. Is a case question of what we will call a genetic code or a zip code issue, right? So we think mostly it's a zip code issue, and this is where it gets me to the point to answer your question. I wanted to prefix that to answer that question, which is that most of our people are living in areas of what we call medically underserved areas, meaning you are getting to be treated by people who are not really on top of their game for in the space in which for those diseases. Sometimes they're being diagnosed. The diseases are diagnosed at advanced stages. Sometimes there are also the fact that maybe because of issues of insurance and so on and so forth. So these are some of the reasons why our people ultimately get much worse outcome compared to a lot of the white folks. And for urology, it's not every urologist who is a urologic oncologist, meaning two terms here, right? Not every urologist should be taking out your prostate for cancer. The normal, regular trained urologists they're good to do things like take out a benign prostate, but you need additional training to become a urologic oncologist, to learn how to do surgery in the, cancer surgery in that area. Just similar to me I'm an internist. I did internal medicine, but I also did an additional 4 years of training post internal medicine to become an oncologist. So somebody cannot just say, hey, look, and even then, this is what I do day in, day out, and that's all what I do. Somebody cannot just say, okay, maybe. So the conversation I'm going to have with you about your PSA, about how to treat your cancer, it's going to be a very, very different conversation from somebody who dabbles into this and who is not the expert in that area. So when you are asking for your surgeon, get this actually, be bold enough, polite enough to ask your surgeon, how many of this have you done, right? What is your complication rate, right? It's your body.
I can tell you, if you ask our doctors in Africa, one could punch you in the face.
Yeah, because that is actually a big problem that we have here in the US. Actually, I need to push a lot of my, my patients who come from, Africa, or who come from medically underserved. Who, I have to remind you, we're not gods, right? Doctors are not gods. So all I need to tell you is just make sure that I need you to have all your questions answered. And for people who don't have, and please also if you are here in the US and you need to be able to get, if you are not very comfortable with what your doctor is telling you, ask to get a second opinion. All right? Ask to get a second opinion. But you go on the website, for the most part, you find out a lot more about your doctors, about what they do. Then you can ask them about how much, and that goes for every procedure. Anything that somebody is going to do to you. And if you're the expert, why should you not be happy to discuss this information about people who are actually remember, this is their life. It's not like you're going to buy a car that if you don't like, you bring it back, right? This is
Absolutely.
your life, and you should be bold about it.
You are watching Healthline on Chat Night Africa. My guest is Professor Edmund Folefac. He's researching some of the latest cancer treatments, and also is an oncologist. I have a question, actually 2 questions. Everybody told me to bring this question to you. Before those questions are brought to you, I will be asking that we listen to this musical interlude, and I'll be right back for those 2 powerful questions.
Strength to push on through.
Hold my hand, never let me down. Professor Folefac is here to hold your hand to never let you down. And he's the only doctor, and I've interviewed so many doctors on this platform. He is the only doctor who comes here and says, look, if you have this problem, call me. None of the doctors I brought here ever said that. I don't know why it's doing that. But you have to understand that this is a guy who is 1000% willing, ready to give back to society. Ladies and gentlemen, as I told you, going forward, and this is the big announcement, going forward, Facebook will not be keeping any live videos for more than 30 days. So what then do you do? Go to www.chatnightafrica.net. You can see it scrolling below me, scrolling. Go there, you will find our videos, our broadcast videos. We've upgraded the website thanks to some friends who donated money so that we can do this for you. You can go there, you can go to YouTube, search Chat Night Africa, and you will watch in both places in high definition. If you like, high resolution. I want to thank two people, Mr. Mumbalingwa, who is in Chicago and my director of transmission, and my lieutenant in Nigeria. He is the platform's manager. He manages the technical aspects of my broadcast. That's Mr. Ze Roger Fole. So talented, truckload of talent, but beyond that, very, very passionate, dedicated in what he's doing. Dr. Elo is the guy who designed this platform. Thank you, Dr. Elo. So you see, to get this broadcast quality involves pooling a lot of talents together. You know, you conjugate a lot of talents to be able to get the kind of things that we are doing right here. Ladies and gentlemen, at this point, I'm going to invite you once more to meet Dr. ProfEdmundFolefac on the platform. Doc, I have two questions. Everybody told me, Divine, make sure the doctor answers these questions. Two. Question number one: what are some of the latest advances in prostate cancer treatments?
So that there are many, and we're just so excited about the what is coming. Number one, there are new forms of hormones therapies that are being developed and combined with the old treatments that we had. The second thing that we've had now is something that we called the PSMA directed therapy. The cancers have some proteins on their membrane. We've been able to figure out a way to be able to find some form of radiation that is attached to that protein that the cancer then takes in, and then it kills the cancer. So that's really the other part. And then thirdly, we're actually in the position now where there are now some of the things that are used for already in some of the cancers, some form of lymphomas that we call the CAR T cells. I call them my guided mix. And that is actually, again, figuring out a way to load, very some kinds of chemotherapy, or if so, some form of figuring out how to get your immune system to go and attack the prostate cancers through different mechanisms. So there's a lot of advances that is actually being developed now. And then the last one, the antibody drug conjugate, that is also being developed. We've been able to find a lot of the genetic mutations, and some of these are weaknesses that are inherent in the cancer. And sometimes that we are able to combine, or either use that as a standalone, but combine it with some hormone therapy. We talked about the last time, we talked about the BRCA gene, which actually confers breast cancer, high risk of breast cancer. It does also do the same thing for prostate cancer. These are proteins that, these are things that help you repair the DNA, which is like the instructional manual. Sometimes they've been able to develop some of these drugs, combining them with other pills in prostate cancer for a certain class of patients really has worked very well. So it's I think ultimately, I think the holy grail where I am looking for to eventually see if we could be able to, whether we will eventually get there, is this idea of being able to treat prostate cancer in a way that we could still use the some form of hormone therapy, but not really that which would affect men's sexuality. That is something that we really, really need to work hard at getting at. We have not been able to do
Are
that.
you any close to getting it?
I don't think so. Because prostate cancer, by its nature, is addicted to the male hormone, which is actually the your testosterone. And so there is not a way yet that we've been able to figure out how do you treat prostate cancer without, just can you be able to figure out a way to block the hormone from just reaching the prostate cancer, but allow the hormone, the testosterone, to still do what it does for men, which is, because beyond the just the sexuality, there are so many other things that the hormone, the testosterone, when we cut it off from reaching the cancer, there are so many other problems that it causes. Like people lose muscle mass, people then begin like accumulate more fat, leading to certain things that we may call metabolic syndrome. There may be some little affectation over time on people's strength, and then some people may tell you that their memory gets a little bit, I'm talking here about people who have had advanced cancer, that is no longer curable, but we're just treating with all these drugs. So there is a lot, but honestly, we've come, very, very a long way to then see today when even somebody with advanced prostate cancer sitting in front of you, and you're knowing that, it's not no longer just a death sentence that the person will be dead in a couple of years, but that people can live for a really long time. I have people in clinic now, 10 years out and things like that with advanced prostate cancer. That was hitherto kind of things that we just didn't really think that we'll get there.
Another
So
big one.
there's a lot
Another
of science. Yeah.
another big one. Are there medications that could prevent the cancer? The cancer here, prostate cancer.
I think that there's been a lot of myth out there, that there are medications that can prevent prostate cancer. But not exactly. There is something that we call a class of drugs that we use, for instance, to decrease the size of the prostate. We use it to treat benign prostate enlargement. That class of drugs can indeed reduce the PSA. But the caveat there is that when we did the study, when we looked at the studies, all the studies that have been done on that, even though it decreases the amount of the number of cancers generally, but paradoxically, it did lead to a higher, an increase in the number of people with higher risk prostate cancer, which makes you wonder whether, because that drug itself tends to decrease the PSA, that it's not kind of like causing us to miss the low grade prostate cancer and then just only seeing the high risk, the high grade ones. So, and they've done other studies looking at things like vitamin D, vitamin E. They've been, which really just have not panned out in a way that I would say that one would recommend. There are other things there that have been looked at. Lycopene, which is something that is a chemical that is found in tomatoes. There is also soy, the soy from the soy plant that we eat. But the problem with these things, dietary things, is that it's the quantity and how it is prepared. When I talk to my friends who are actually researchers in in nutrition. They'll make you the point that, just eating something, when you eat a raw tomato versus cooking it versus
I was
frying
going to
it,
ask you that. Maybe I
can
should now
change.
go to
Yeah.
a grocery store and buy baskets of tomatoes and
No,
eat them
no,
every
no,
evening.
no. I think
If it has
ultimately,
lycopene.
yeah. So, but then we know that again, when you eat it, the lycopene, take this analogy. Water quenches fire, right?
Right.
But how much water, right? So
Okay.
you're going to buy lycopene. So that is one of the challenges that we have. But what we do know from every available study that you look at, it's again goes back to the conversation we had last time about breast cancer. And it would go back to even if we were having a conversation about diabetes, about anything else. Please, whatever you do, what you eat, ask yourself what great grandma would have eaten. Because it would have been more vegetable, fruits, and whole plant based. They didn't have fast food. They didn't have fast food chains of fast food or processed food that they will get. They would have eaten from their gardens. That's what you should be focusing on eating. That is number one. Number two, whatever you do, think about it. When you eat and you eat much more than you need, it's almost like a city that has so much garbage. The city will stink because the excess food, when you eat beyond a certain level, what is the excess food? It's just garbage in your body. And your body can process that. Cancers like that, disease like that. So don't eat too much more than what you need to eat. And then number three, so eat more fruit, plant-based, whole plant-based fruits, vegetables, and things like that. Eliminate the sugars, eliminate the processed food if you can, and avoid, limit your red meat intake to a bare minimum. If you want to eat, maybe fish is better than white meat, and white meat much better than red meat. Number three, your weight. The obesity epidemic here in the US and around the world, brothers and sisters in Africa, when they look up at us in the West, instead of looking at us and pitying us for the large tummies, they think that this is a good lifestyle, and then they want to follow us. No, just kind of whatever you do, I think you need to be able to make sure that you keep your body close to ideal body weight. And exercise. Cancers don't like, oxygen. And cancers like waste. When you exercise, you're not only giving your tissues exercise, you're also actually eliminating all that waste that cancer doesn't like. So whatever you do, I think that these are much more things that you should do. And then we did talk about all the screening, find out about your family history, and know about that. So those would be my recommendations that I would give in terms of what, and when in doubt, you can always call me. You have my phone number. You can share it.
Could you read the number again, sir?
978-766-1816.
Okay, and this is what Dr. Bernadette Atanga says. Great content and much needed education for our community. Thank you, Dr. Bernadette Atanga. I have the last question on the show for you. Professor Edmund Folefac, does it sadden you that someone dies from prostate cancer? Why is that? Why, with all the information that you've given, why should somebody still be dying from prostate cancer? What's happening?
So,
Or what may have happened?
yeah. All right. I would answer that question. Let me tell you a joke. Something we talked about, a joke in medicine. We ask, and I tell all my trainees this: what is the difference between God and man, and God and doctors? At least God does not claim to be a doctor, right? What does that mean? That doctors should not claim to be gods, right? Because God doesn't claim to be a doctor, doctors should not claim to be gods. That said, prostate cancer remains one of those diseases that we really can prevent. And if you cannot prevent it, we can catch it early and treat it early. If we catch prostate cancer early at a localized stage, your chances of dying from prostate cancer actually are essentially close to within like the timeline of about 5 to 10 years is essentially almost zero. But when you catch it late, when it's metastasized, your chances of dying from prostate cancer within 5 years, of surviving prostate cancer 5 years after it has metastasized, is probably on the order of 30 to 40%. Now, think about, actually, I would walk you back a little bit. Around the early 2000s, America said, hey, every man should get PSA screening. Everybody was getting it. But I can talk to you about it, that people were not able to differentiate which of these prostate cancers shouldn't be treated and which should be treated. And that actually got a lot of people to take out their prostate. So some people suffer from incontinence, some erectile dysfunction, and all those stuff, and so on.
Wait a minute. Let me stop you there. When you take out the prostate, you say that could lead to incontinence? I just wanted to make sure I understand you.
Yep. The prostate is actually sitting on top on the neck of your bladder, right? And so when you go to pee, the prostate actually needs to relax for the pipe that takes urine from your bladder out to open up for the urine to pass. But since the prostate is sitting at the back there, if the prostate has the muscles that controls that we call that the sphincter. If in taking out the prostate, somebody didn't do it well, you could injure that sphincter, and that could cause some urinary incontinence in a group of people. Now, this were some of the things that led the U.S., the Preventative Service Task Force in 2012 to say, nope, nobody should get screened for PSA. And that's what's telling you that it was a very ill-informed decision. Now, you fast forward to by 2017, American Society of Clinical of Oncology of Cancer, a cancer society, did a big study to look, and we're seeing a lot of people come down with a lot more advanced prostate cancer, and many of those were, of course, blacks, right? There was a high preponderance of black people who actually had, more advanced prostate cancer that died from it, and I think, and the reason was, and then they had to go back and revise the guidelines and say, oh, yes, have a personalized conversation with, or a joint decision making with your doctor. Now, I can tell you, and I think I was interviewed, I think I gave an NPR interview on this in 2020. So that the reason why we thought this was happening was because even though the Service Task Force said, do not screen for PSA, many of the people who lived in the affluent areas in the US, many of the people who had doctors that were better trained, they were still getting PSA screened. It is our people who were actually in the place where somebody needs to just check and say, oh, what do the guidelines say? What we will call cover your ass medicine here. I just need to do the bare minimum. It's our people who didn't get the PSA screen. And those are the people who eventually developed advanced prostate cancer and died from it more. So now they say the guidelines should be so the point there being, again, get your PSA screen. Now you know that you should get your PSA, and if you need more help, get us to actually help you interpret the PSA. If you need to do that, that's really what I would say. Again, I know many of us in Africa just don't know our family history, that much. Or you go and the doctor is asking you about family history, and you don't, you're asking yourself, like I used to ask myself when I was in secondary school, and I would go to the doctor and asking me family history. I'm like, are you not supposed to be the doctor? Why should you be asking me?
Why you be asking?
But
Why you
now
asking
I
me?
know better, if that can inform them where to put you in terms of risk, and how to actually be able to continue to follow you up. If you had a family history, then you should be getting screened even more often, yearly, and things like that. So yes, it saddens me that some of the people who die from prostate cancer should never have died from it. Because if they were screened, if they got information, if they got informed, and they had people around them who they could discuss this information with them, they would have actually been, guided much better, and then they would have had a better outcome, a different outcome.
Before we go, I'm going to ask for your last word in just 1 minute.
Last word. If you're married, if you're a woman, get your husband to get their prostate cancer screening. If you are a sister, get your brother to get your prostate cancer screening. If you're a daughter, and you know that your dad is a certain age, and all of them are above a certain age, 45 and since and black, ask them if they had actually had their screening. If they screen, you can then ask them if there is any ambiguity. You can reach me, but I'm also sure there's so many of us doctors who are actually out there willing to help, who would help you interpret this actual data. And as you go, please remember the things I said: exercise, eat right, sleep well, and think right.
Thank you so much. Soon, Professor Folefac will be coming back here to answer. There will be another broadcast on Healthline on Chat Night Africa. He will be coming here to talk about the kinds of screenings. What medical checkups should you do at what age? Listen to me again. What should you be checking out for at what age? Stay tuned. That's going to be a hot one. Doctor, I want to thank you so much indeed for coming to answer my questions. I appreciate you. You can see questions coming in from, this is Dr. Benedetta Tanga. She says, thank you, Prof. Thank you, Doc. You've been doing a terrific job as well. At some point, you will be my guest on Chat Night Africa. You are watching the tail end of this broadcast, and we just had Professor Edmund Folefac. Listen to me once more, this important announcement. Going forward, Facebook will not keep broadcast live shows on that platform for more than 30 days. What should you then do? Go to www.chatnightafrica.net to watch our shows. They are there forever and in high resolution. You can also go to YouTube and search Chat Night Africa. You have all our shows there. I'm saying this because this show you are watching will not be on Facebook after 30 days. Thank you so much. I want to take this opportunity to thank all the people who have been dipping their hands into their wallets so that we have this quality of broadcast. When we started 4 or 5 years ago, it was nothing close to what you are watching now. My name is Divine Chamokong. It's on this note, ladies and gentlemen, that I say merci à tout le monde. Time I go, every good thing has an end. I will see you soon and very soon. And once you hear this jingle, it's time we say goodbye.
I'm coming back. I'm coming back. I'm coming to get down. I'm coming to dance, We're gonna dance, we're gonna get down, we're gonna party hardy. We're gonna boogie woogie, and when we jam, it's out of sight. This song right here, it's dynamite. I'm ready.